Karen, good to see you. And
Hey.
tell us a little bit about trans-tympanic drug delivery. And Karen has a tremendous background, comes from Atlanta, and he spent a year or two with Dr. Silverstein, who really developed this methodology and what really involves in intratympanic drug delivery. Go ahead, Karen.
All right, terrific. Thank you so much. So your $1 million question was whether or not we can actually deliver drugs to the inner ear. So I am going to address that issue as soon as I can get my computer to work. All right, so when we look at the anatomy, we always have to start with basic anatomy. For the inner ear, we're talking about mainly hearing loss, tinnitus, and vertigo as those clinical symptoms. And so what we find is it's really the bony otic capsule that is the major anatomic and physiologic barrier to delivery for medications into the inner ear. So we have several different barriers. Initially, the tympanic membrane that then takes you to the middle ear space. And then we have the oval window and really the round window. And then this bone is super dense. It's the densest bone in the body. So it's really a barrier to getting drugs into the inner ear. So when we look at what we're doing now in comparative analysis, the limitations of traditional delivery through systemic, the reasons that's bad are the reasons that intratympanic delivery is better. So we look at systemic drug distribution. We can't really get it to the site of action as easily, so there's less precise targeting and broader side effect potential because it is distributed throughout the body. So the trans-tympanic, if we can get it into the inner ear or middle ear space and absorbed into the inner ear, you can have higher local drug concentration in the ear, better targeting, and a reduction of systemic side effects. And we always love a non-invasive approach too. So if we look at the schematic about systemic drug absorption, then, and those are things either orally or intravenously. So they're really a problem because we can't really get it into the inner ear. So because of that very dense bone, a lot of the medication may just be outside in the periphery. It's not actually getting into the membranous space. And so what we find if we can get it into the membranous space is really where the target is. So intratympanically, so if you look at the arrows, the red arrows, the bigger red arrows are the things going in the perivascular space and circulation. And then you can have some of the stuff coming out of the drugs, potentially coming out of the eustachian tube and also out of the round window. This is really the entry point into the inner ear. So it can address, if we can get through the round window membrane, from the middle ear space, we can then get into the cochlear space and also into the vestibular space. So we could potentially address not only the hearing aspect of the inner ear, but also the vestibular system. So most of that is coming through a passive, maybe passive movement across the round window membrane. So here's what we're doing now. So we have some experience doing this already. So it started initially with probably sudden idiopathic sensory hearing loss, where the first studies were using trans-tympanic dexamethasone in patients that were treated initially with IV steroids. So this was like a rescue performance where these patients did not have significant clinical improvement. And so what they found is you actually get significant improvement in hearing thresholds compared to the control group when you do intratympanic steroids, even after potentially oral or IV steroids. We're not really using very many IV steroids, or I'm certainly not as an otologist, but we are using a lot of oral steroids in our patients with sudden hearing loss. And we think the mechanism is that it reduces the inner ear inflammation. So when we look at our clinical practice guidelines, currently those were done in 2019. It is felt that clinicians should offer or refer to someone who can offer intratympanic steroid therapy in patients who have incomplete recovery from sudden idiopathic sensory hearing loss. There is a little window of opportunity of 2 to 6 weeks after onset of symptoms, so we do have to get that going fairly quickly. We're also treating patients potentially with Meniere's disease, and as we have talked about before, some of that Meniere's disease patient, the clinical picture really mimics a lot of otologic and vestibular migraine. So how much are we treating what we thought was endolymphatic hydrops or Meniere's disease there? But some of the initial studies, I trained with Herb Silverstein, and he likes to use this microwick. So the way the microwick works is you put a little tube inside the tympanic membrane, just like you would for, it's a tympanostomy tube, and you have this wick that goes through the tube, and ideally it abuts right up against that round window membrane. So it delivers medication that you put into the ear canal as close as you can get it into the near the round window in the niche, and then it's absorbed into the inner ear. So what he found is using gentamicin, it's vestibulotoxic, and it can hopefully target that vestibular system so that you knock out the vestibular system, but you preserve the hearing. So they had found 90% successful vertigo suppression and 80% reduction in vertigo attack frequency. So we want the selective ablation. There have also been some studies looking at tinnitus management, where they looked at trans-tympanic lidocaine, and they found 40 to 50% of patients experienced significant relief, but it was temporary. So temporary tinnitus suppression, the duration of effect was about 2 to 4 hours post-application. So we'd love to find a cure for tinnitus, so still working on that. And then also there were some models looking at ototoxicity prevention, and these were done in an animal model. And we did talk about how much of the animal models are really resembling human models. And I don't know that we haven't figured out if they can be converted to humans, but they did intratympanic antioxidants as protection against cisplatin-induced ototoxicity. So that definitely knocks out a lot of our sensory hearing loss. And so if we can find a way to preserve cochlear function by mitigating the oxidative damage without affecting the systemic side effects and cancer treatment, then we can have potential for lessening those side effects of therapy. And when we really think about it, what we're doing now for all the intratympanic medications, we're using medications approved for systemic administration in an off-label use. It's not the first time we've done off-label use of medications, but we're injecting them intratympanically. Most of them are in the form of an aqueous solution. But the problem is there's so much variability. There's variability in how often people do injections, how much medication they're actually getting in there. And that can be because of patient factors or just how the clinician is doing it. So there's so much variability. I think we need to figure out that also. Now, there are some emerging delivery techniques. There is some ongoing research that can be helpful, and we may be able to apply that. One is microneedle patch technology developed by Stanford Bioengineering Department. So these are 3D printed microneedles, very teeny tiny. And these are they can range between 100 and 500 micrometers. And they are made usually of biodegradable polymers that minimize tissue disruption. And so what they found is once you inject even the round window, you can get some spontaneous healing within about 72 hours. So that may lessen our side effects. And in the guinea pig model, these were actually used in the cochlea. So they delivered dexamethasone into the cochlea with no significant changes in auditory function post-injection. So they did some auditory testing, and that appeared safe. So I haven't seen anything yet applied to a human model, but we hope that that could be something that we can develop. You can get significantly higher doses of drug into the inner ear than what you could get through conventional or traditional drops. And the big challenge here is that you can have a lot of variability in the tympanic membrane and round window membrane anatomy. And so that can pose some procedural challenges. And it would also be potential for integrating those into things that we're already doing. So like hearing aids or cochlear implants, if we could integrate that in there and deliver medications through that, that might be an existing option of the. All right, so next one is nanoparticle. Hydrogel. Let's go back one more. Nanoparticle delivery systems. So in the study with Kim et al., it investigated the use of nanoparticles for treatment of inner ear diseases. So they developed a new type of nanoparticle that was able to deliver drugs directly to the inner ear. And they found that this significantly improved drug delivery efficiency and reduced the side effects, at least in some animal models. So these are teeny tiny particles, usually less than 100 nanometers in size, and they can carry drugs directly into the target tissue and potentially penetrate the blood-brain barrier and the inner ear barrier. And so this can improve drug delivery efficiency and reduce side effects. And so where they can potentially use these would be targeted gene therapy. So if you functionalize these with specific ligands or antibodies, they can get into the target cells to express particular receptors. So there may be a role using gene therapy for congenital hearing loss potentially. You can do controlled release mechanisms, so you can have them almost like sustained effect. You can have, they can release their payload over an extended period of time, so you can have increased concentration of the drug in the inner ear potentially, and also have it stick around a little bit longer. And that may also decrease the frequency that you have to do either injections, and so also could improve patient compliance. They're looking at some triggered release potentially. So things like changes in pH or temperature or the presence of specific ions may cause the triggered release of medications. So that gives us a lot more flexibility in how we treat patients. Sometimes they thought one of the challenges could be that the immune system may recognize these as foreign substances, so they could increase clearance, which would reduce their therapeutic efficacy. So this is a really interesting idea in trying to get drugs into the inner ear space. And if we look at hydrogel-based carriers, these are, the drugs are actually loaded into the hydrogel, and they can diffuse potentially across the round window membrane, and then they can be released in meaningful concentrations. And so if we look at options there, the good news about these were developed by Northwestern University in biomedical engineering. So you can get long-term sustained drug release, so it can last longer because it forms a depot that can slowly release over time. So again, minimizing repeated administrations and potentially improving patient compliance. You can get potentially some personalized medication strategies, and where you can just target like when to use it and how much to release. And then adaptable to various drug molecular weights. So one of those challenges is trying to get different size drugs, particularly bigger ones, into the cells, and that's such a small space. So you can have pore size and degradation rate can be adjusted potentially for different drug molecules. And you could potentially do targeted delivery, just like you can with the nanoparticles, because you can put targeting ligands on this to deliver drugs to specific tissues or targets. And then electroporation techniques. So the way this works, as you can see from the little diagram here, that the electrical pulses, if you have a closed cell, you can't get the drug in there. So you put electrical pulses can increase the membrane permeability. So it creates these pores that allow the drugs to go into the cell. And then once the electrical pulses stop, it heals up. And so it allows you to get drugs into the cells that you wouldn't otherwise. So it can maybe enable delivery of larger drug molecules in there and enhance penetration potentially by up to 200 to 500%. And so again, gene therapy, that might be an option for patients that need a vector to the inner ear, potential treatment for genetic hearing loss, potentially, which is very exciting for us that do a lot of ears, and complex molecular treatments, and also challenging drug delivery. So all of these things will allow things that wouldn't normally pass across that membrane potentially to get into the inner ear. We do need to examine whether the high voltage pulses can potentially damage the tympanic membrane or round window membrane and surrounding tissues. All right, so there are some future resources. Before we do that, let me just tell you a couple of things that I think are key when we talk about the round window, because that seems to really be the entry point into the inner ear. So if we can get things through the TM into the middle ear space and through the round window, then we can get it potentially into all those aspects of the inner ear. And so I found it was really interesting that the round window membrane, it changes in permeability depending on several factors, including anatomy, physiologic state, and also the external conditions. So things like smaller molecules, of course, are going to pass more readily across the round window membrane, but hydrophilic molecules pass less or pass slower than lipophilic ones. The charge makes a difference. So neutral particles can permeate the tympanic membrane and a round window membrane more easily than charged ones. If there's inflammation, it's very interesting. Acute inflammation, like we were talking about for acute otitis media, makes that membrane more permeable, but chronic infection and inflammation or scarring will actually decrease a lot of that ability of things to pass through that membrane. And then a couple other things, chemical agents, so surfactants can be very helpful, or solvents can temporarily increase the permeability by disrupting the membrane integrity. pH and osmolarity can also do it, and also temperature. So high temperatures will allow more drug to diffuse across the membrane. So if we can really target that round window membrane permeability, that's where the key to getting things into the inner ear. So here's some future research directions I'll go over very quickly. If we talk about AI-driven things, artificial intelligence, because of its capacity to be able to look at so much data so quickly, if we look at large data sets, we can identify potentially patterns and correlations between patient characteristics, maybe drug dosaging, and also therapeutic outcomes. So we may be able to target using these AI algorithms to figure out what's best with patient-specific data in treating one individual patient. We can look at combined delivery technique optimization. So if hydrogels are great and nanocarriers are great, what happens if we combine those? We may get even better drug delivery into the inner ear. Same thing with nanotechnology. So there can be synergistic effects that we can target, including targeted delivery, controlled release, and enhanced drug solubility. All those things get the medications into the inner ear and potentially keep it there longer, and can respond to external stimuli. Something like light or magnetic fields may be helpful to trigger drug release. And then here are two other ways we all like minimally invasive things as clinicians. So minimally invasive long-term drug delivery systems. We could potentially look at implantable drug delivery devices like little micro-osmotic pumps, like the picture, down low on the left-hand side. So if we can implant those near the middle ear, they can deliver drugs at a controlled rate over an extended period of time, and polymer-based implants that can be loaded with drugs and potentially implanted into the middle ear, so providing sustained release and increased drug availability in the inner ear. And very quickly, couple of limitations, always currently anatomy. I'd love to say we can always get drugs, even if we can reach the tympanic membrane. There's so much variability in anatomy, whether that's the position of the TM or whether you can even access the round window through the middle ear space. So that's always going to take in consideration. And there's limited drug volume capacity, both in the middle ear space, unless it's going to come out that eustachian tube, and in the inner ear. We want to look at potential membrane damage risk and membrane for the tympanic membrane, but also the round window membrane. And we need standardization because right now, even as clinicians, we don't have great guidelines and people are all over the place. So things that we could certainly work on: personalized membrane permeability assessment. If we can assess how the membrane transmits things in an individual patient, we may be able to improve that. Advanced protecting drug carrier development, and also minimally invasive application techniques. So those are all things that we can do to try to overcome these challenges that we see for drug availability in the inner ear. I'm a speed talker despite my Southern roots, so hopefully that has covered it. And so I would say, yes, I think there are some great options for drug delivery to the inner ear.
Thank you, Karen. Surprisingly, we're on time. Even my puppy is amazed.
Terrific. Good. Glad I could help out. Thank you so much.